Welcome back to Radonc Smart Review, Thoracic Edition.
Glad to be back.
So we've essentially fed our AI this massive stack of recent ASTRO guidelines, multi-institutional retrospective reviews, pharmacology data.
Right, the really dense stuff.
Exactly. And the whole point of this review session is to figure out how to safely weave radiation and systemic therapies together.
Because, let's be honest here. You're sitting at your workstation, it's 5:03 p.m. on a Friday.
It's always a Friday.
Always a Friday.
Yeah.
And medical oncology is asking for clearance to start a new tyrosine kinase inhibitor. Or maybe your dosimetrist is just waiting for plan approval.
Yeah, and you're frantically scrolling and you can't find a clear answer in the NCCN guidelines.
Right. So what do you actually type into that note to protect the patient and, well, to protect yourself?
That Friday evening panic is just a universal experience, I feel like.
Oh, absolutely. But I think the central problem in metastatic non-small cell lung cancer isn't whether we can combine radiation and systemic therapy. We do it all the time.
Yeah, that's routine.
Right. The actual problem is how to make them function as a coherent strategy without overlapping toxicities. It's about biology, not just scheduling.
Which is funny because I see residents do this constantly, They vaguely recall a review article from like a year ago.
Oh, the dreaded drug hold table.
Yes, they pull up a memorized drug hold table and they treat this, 3 days before and 3 days after rule as if it's carved in stone.
Right, but applying a generic timeline without even looking at the field size or the specific organ overlap?
It's incredibly dangerous.
It really is. It's basically practicing administrative medicine rather than biologic medicine.
Yeah, exactly.
So to keep us grounded in the biology today, let's just use an anchor case.
Perfect. Let's do it.
Okay, so we have a patient with biopsy-proven metastatic non-small cell lung cancer. They are currently on an EGFR-directed oral tyrosine kinase inhibitor.
Let's say osimertinib, just to make it specific.
Sure, osimertinib. Their extrathoracic disease is beautifully controlled. But they have this thoracic lesion that is enlarging, and it's causing a persistent cough and exertional dyspnea.
Okay, and here is the referral sitting in your inbox, right? It just says, please radiate the symptomatic site and advise whether to hold the drug.
Just one sentence.
One sentence. I have to laugh every time I see those because that single sentence is a masterpiece of understating the problem.
Oh, yeah. Just zap the spot and tell us what to do with the pills.
Oh, right. It's a terrifying referral if you actually take it at face value.
Well, because right away, the clerical gaps are massive.
Yeah.
We know they have metastatic disease, but we are missing the exact TNM details based on the AJCC version 9 definitions. We don't have the date of their last dose.
We don't know their baseline lung function either.
Exactly. We have no idea if they have a history of interstitial lung disease or, crucially, prior thoracic radiation.
So if you're in the hot seat, right, you're giving the 60-second board answer to your attending. What is the immediate workup before you even attempt to answer that referrals question?
The very first step is to halt the train. You have to confirm the foundation. I need the histology. Yeah. I need the complete disease distribution, which means fresh, high-quality body and brain imaging. I need to verify their biomarker testing. We know they are on an EGFR inhibitor, but what is the exact mutation?
How it's driving the tumor, right?
Exactly. Yeah. And what is the symptom tempo? Is this dyspnea worsening over 3 months or 3 days?
That completely changes the urgency.
It dictates everything. And critically, I need a really thorough review of their prior treatment records to rule out any previous thoracic radiation.
Because if you miss that,
it could result in catastrophic cumulative dosing to the spinal cord or the heart or the central airways.
Yeah, you really have to be careful there. So let's pause on the intent for a second, because before you even open your contouring workspace, you have to define what you are actually trying to achieve.
Right. Intent is everything.
I remember as a resident, I'd present a case to my attending and I would proudly declare, the intent here is SBRT.
Oh, no.
Yeah, and I just get this look of profound disappointment.
Because SBRT is a technique. It is not an intent.
Exactly.
That is a massive conceptual trap that so many trainees fall into. Stereotactic body radiation therapy,
Right.
Using tight margins and high doses per fraction, It doesn't magically confer favorable metastatic biology onto the patient.
Right. The technique does not equal biology. Your intent in this specific case is palliation.
Exactly.
You are just trying to relieve the cough and the dyspnea safely and conveniently. You aren't promising durable ablation of limited disease.
Because ablative intent demands stringent disease selection. It requires rigorous motion assessment and absolute confidence that treating this specific site is actually advancing their progression-free survival.
Which is a huge bar to clear.
It really is.
Yeah.
And we also need to address the other extreme, right? Sometimes you see a completely asymptomatic lesion in a patient with widely metastatic disease, and someone suggests radiating it just to, quote, prime the immune system.
Ah, yes. The elusive abscopal effect.
People love chasing ghosts.
They really do. It sounds so good on paper. Yeah.
It's a fascinating biologic phenomenon, I'll give it that. But it is an immune desert in most of these unselected lung tumors. Randomized evidence simply does not support a reliable, generalizable abscopal effect.
Right.
Giving local radiation without a valid local indication, just hoping to trigger some systemic immune cascade, you are exposing the patient to real toxicity for a completely hypothetical benefit.
Yeah, the local indication just has to stand completely on its own merit.
Always.
Okay, so we've established our intent. It's palliative. We are treating this patient to stop their cough, but they're scheduled to take their next osimertinib pill tomorrow morning.
Right.
Who yields? Does the radiation take priority or does the systemic drug?
For broadly metastatic disease, you have to remember, the systemic therapy is the disease-wide backbone. Radiation is essentially a sniper rifle brought in to solve a defined local problem.
I love that analogy.
But the order of operations depends entirely on clinical urgency.
Okay, let's unpack the pharmacology of washouts then, because this honestly drives me crazy. Say you have a true emergency malignant airway compression, or maybe massive hemoptysis.
Scary stuff.
Right. I have seen teams delay urgent palliative radiation for 2 weeks just to achieve a, quote, pharmacologic washout of a targeted drug.
Aren't we just watching the patient choke while we wait for 5 half-lives to pass?
Yes. Yes, we are. And that is a massive failure of clinical judgment. If a lesion is actively bleeding or it's causing near-term airway compromise, you treat it, period.
You can't just sit on your hands.
No, you can't. You might modify your radiation technique, maybe use a simpler field or accept a slightly higher risk of overlapping toxicity, but you absolutely cannot delay an emergency for theoretical purity.
Plus, with many modern monoclonal antibodies or immunotherapies, the biologic persistence in the tissue, the actual receptor occupancy, it lasts for weeks or even months.
So skipping a pill does nothing anyway.
Exactly. Missing a few days of a pill or an infusion does not magically erase the drug's effect from the lung parenchyma.
Speaking of things that drive us crazy, let's talk about the trap of importing stage 3 habits into stage 4 disease.
Oh, this is a big one.
Yeah. I remember as a junior resident, I'd see a metastatic patient getting systemic cytotoxic chemo, and I'd think, great, let's radiate them concurrently for that sweet synergistic effect.
That is a terrible idea here.
It's a devastatingly bad idea.
Right, because concurrent cytotoxic chemoradiation is a purposeful radiosensitizing strategy. We use it in stage 3 curative intent because we are willing to push the patient to the absolute brink of their physical tolerance to cure them.
Yeah, we accept this severe esophagitis.
We accept the pneumonitis, the marrow depletion.
Yeah.
But in stage 4, palliation.
It's totally different.
In stage 4, the goal is symptom relief without compounding their misery. If you accidentally radiate a large thoracic field while the patient is receiving concurrent platinum doublet chemotherapy, just because the calendars happen to overlap.
Which happens a lot, actually.
It does. And you're causing shared tissue injury. You're depleting the stem cells in their bone marrow and esophageal mucosa for absolutely no survival benefit.
Right.
Concurrency in metastatic disease must be an explicit, deliberate, multidisciplinary choice. It's usually reserved for very specific oligometastatic paradigms, not a scheduling accident.
Okay, so we know we need to treat our anchor patient urgently for their cough, but we obviously want to avoid accidental overlap with their EGFR inhibitor. How do we actually make the drug hold decision without relying on a useless static table?
We need a framework.
Right.
So we use a 7-question framework. The mnemonic is IANVTHR.
IANVTHR.
Yeah, I am not very thrilled, honestly. Yeah. Restart.
Let's break that down because I think this is vastly more useful than just memorizing days on a chart.
Absolutely. So I is for intent and urgency. A is for the specific agent. N is for normal tissues in your field.
Okay.
V is for volume and fractionation. T is for prior toxicity. H is for the harm of interruption. And R is for restart owner.
Let's apply that to the biology, starting with cytotoxic chemotherapy. The N normal tissues and the A agent are really critical here.
Very critical. If you are palliating, say, a small rub metastasis with A gray in a single fraction, the shared tissue injury with systemic chemotherapy is pretty negligible.
Because the volume is so tiny.
Right. But if your field includes a massive volume of lung, esophagus, and active bone marrow, the toxicity multiplies.
Yeah.
The radiation causes double-strand DNA breaks, and then the chemotherapy prevents the cellular repair mechanisms from fixing them. You just get compounding necrosis and inflammation.
Wow, yeah. Let's pivot to immune checkpoint inhibitors, then the ICIs. The A factor here is defined by really long biologic half-lives.
Huge half-lives.
Like IgG4 antibodies like nivolumab or pembrolizumab, they basically stay in the system forever. So holding it for 3 days before your radiation simulation does literally nothing biologically.
Exactly. Because of that persistence, the extreme rules are both false.
What do you mean?
Well, immunotherapy is not always safe with thoracic radiation, nor must it always be held. We actually have robust prospective data showing they can be combined safely. But the T in our mnemonic prior toxicity is the vital red flag.
Okay, walk me through the mechanism of that. If a patient had a prior grade 3 immune-mediated pneumonitis, why is thoracic radiation suddenly so dangerous?
It all comes down to T-cell exhaustion and reactivation.
Okay.
Immune pneumonitis occurs when the checkpoint inhibitor unleashes T-cells against normal lung parenchyma. We usually treat them with steroids, right? And those T-cells become suppressed or exhausted.
Right, they go dormant.
But when you deliver radiation to that same lung, you cause cell death. This releases neoantigens and just massive amounts of pro-inflammatory cytokines like TNF-alpha and interleukins.
So it wakes them back up.
Yes. This cytokine storm can suddenly reactivate those dormant autoreactive T cells, triggering a massive recall pneumonitis that can easily be fatal.
Oh, wow.
Yeah. So if a patient has a history of severe immune pneumonitis, elective thoracic radiation must be approached with extreme caution, heavy pulmonology input, and an aggressive effort to minimize lung dose.
That makes total sense. Let's bring this back to our anchor case. Our patient is on osimertinib, an EGFR-directed oral TKI. Now, this is heavily tested on the oral boards.
It sure is.
Let's look at the stats from the principal multi-institutional retrospective series of 102 patients.
Right. So in that specific series, grade 2 or higher pneumonitis occurred in 13.7% of patients receiving osimertinib and thoracic radiation.
13.7%.
Yeah. Grade 3 was 2.9%, and grade 5, meaning fatal pneumonitis, was 2.0%.
13.7% for grade 2 plus is a real sobering number. But here is where I think residents misinterpret the data. In that exact same series, holding the osimertinib versus continuing it right through the radiation did not show a statistically significant difference in the rate of pneumonitis.
That's the tricky part, yeah.
What did correlate with toxicity was the mean lung dose, the MLD.
And we really need to explain the biology of why MLD matters so much here.
Go for it.
So the epidermal growth factor receptor, EGFR, it is not just a cancer driver. It is fundamentally essential for normal mucosal and epithelial repair.
Right, the normal cells need it too.
Exactly. When radiation damages the type 2 pneumocytes in the lung, those cells rely on EGFR signaling pathways to repopulate and heal that alveolar capillary barrier.
So if you were blasting the lung with radiation, causing massive DNA damage, and simultaneously giving an EGFR inhibitor that blocks the exact pathway those cells need to heal,
You are essentially guaranteeing unchecked inflammation and fibrosis.
you are blinding the lung's repair mechanism.
Precisely. This is why you cannot conclude that holding the drug is useless just because of a lack of statistical significance in one retrospective cut.
The data is just too heterogeneous.
It is. The data support deliberate coordination and keeping the mean lung dose as low as physically possible. They do not support a rigid, always hold for 5 days rule, nor do they support blindly treating through without a thought.
But wait, let's talk about the H in our mnemonic harm of interruption.
The other side of the coin.
Yeah, because if we hold the osimertinib for 3 weeks just to make our radiation dose feel safe, what happens to the systemic disease?
You risk oncogene addiction rebound.
Disease flare.
Right. These tumors are biologically addicted to the suppression of the EGFR pathway. If you abruptly withdraw the TKI for a prolonged period, the suppressed extrathoracic microscopic disease can just explode.
So you might perfectly palliate their cough, only to have them return a month later with 10 new brain metastases.
Yeah. Exactly, which is a disaster. This is why the coordination must be incredibly tight. The interruption should always be the shortest, clinically reasonable interval.
What if the referral wasn't for a TKI, but for an anti-angiogenic, say a VEGF inhibitor like bevacizumab? I usually apply a massive high concern label here.
Oh, and you absolutely should. The concern is catastrophic, fatal hemorrhage.
Because of the blood vessels?
Right, VEGF, vascular endothelial growth factor. It's critical for the survival and integrity of the endothelial cells lining our blood vessels. And radiation directly induces endothelial cell apoptosis.
So if you have a central cavitary tumor that is invading a major airway, or maybe a major pulmonary artery,
And you irradiate it, causing the tumor to necrose and the vessels to weaken, while simultaneously blocking the VEGF pathway that the vessels desperately need to repair themselves.
it's a recipe for disaster.
You get massive wall failure. The patient bleeds to death. And this risk, it doesn't just vanish because you skipped one dose on the morning of radiation.
Right, the half-life.
The biologic effect on the vasculature persists for a long time. Elective, high-dose treatment near a central airway or major vessel in a patient on a VEGF inhibitor requires explicit, documented agreement with medical oncology, and honestly, often a totally different local strategy.
And then we have the novel agents, the antibody drug conjugates, or ADCs, and bispecific antibodies.
Oh boy.
I had a case last year where a patient on a new HER2 directed ADC needed thoracic radiation, and I spent 3 hours on a Friday night just trying to find a single case report on safety.
It's terrifying when the data just isn't there.
It is the Wild West.
It really is. And the golden rule here is, do not convert the absence of a reported interaction into proof of safety.
Right.
Just because nobody's published a paper on the toxicity doesn't mean it won't happen to your patient tomorrow morning.
You really have to play pharmacologic detective. You have to ask, how does the ABC work?
Yeah.
It's a targeted antibody linked to a highly toxic chemotherapy payload. What happens if the radiation increases vascular permeability in the lung? What if the radiation somehow destabilizes the linker molecule prematurely?
Suddenly, you are dumping a massive dose of unbound topoisomerase inhibitor or microtubule disruptor directly into the irradiated lung tissue.
Which is horrifying.
It is. You have to ask, what are the expected pulmonary or mucosal toxicities of the drug alone? If the proposed radiation field includes that specific at-risk organ, you escalate.
You don't just wing it.
No, you call medical oncology, you talk to your clinical pharmacist, and you write a highly detailed, defensible chart note.
You literally write, no validated universal hold interval is available for this novel agent. The proposed field includes lung, and the agent has a known pulmonary toxicity signal. The multidisciplinary team agreed to interrupt the drug for the shortest clinically reasonable interval, and we will restart only after direct symptom review.
That note defines your rationale and protects the patient. It's perfect.
So we have our hold plan in place for our anchor case patient on osimertinib. Now we move to the planning workstation. And this brings to mind a great way to visualize this. It's kind of like if you have two musicians playing a duet, but they're in different rooms.
Oh, I like that.
Yeah, if the radiation oncologist and the medical oncologist don't have a conductor, they're just staring at their own sheet music.
Right. They play at their own tempo and they end up playing over each other. And in our clinic, that overlapping dissonance is compounded tissue injury.
Exactly.
But they also can't stop playing entirely because the melody is the systemic control of the disease. The radiation plan and the drug schedule are interlocking parts of one unified strategy.
Which means your pre-simulation order needs built-in flags. It must explicitly state the last dose, the intended sequence, active home oxygen use, and any prior thoracic radiation.
Because if you see prior thoracic radiation, you must order a formal dose reconstruction. You cannot just casually assume your new palliative field is small enough to be safe.
Yeah, that's a huge pitfall. Let's talk about adaptive planning too, because anatomy changes. Say your patient with the cough has a large pleural effusion at the time of simulation.
Very common.
And then, a week into treatment, the effusion rapidly resolves.
From a physics standpoint, that is a massive problem.
Why is that?
Because the effusion scatters and absorbs radiation very differently than air-filled lung tissue. If the fluid just disappears, the path length of the beam changes. The Compton scattering profile changes.
Oh, wow.
Suddenly, the dose to the heart or the spinal cord might be vastly higher than what your original treatment plan calculated.
That's terrifying.
It is. If the anatomy changes enough that it alters your target coverage or increases normal organ exposure, you must repeat the imaging and do adaptive replanning.
Now let's address the failure mode in this whole process. This is the orphaned restart.
Oh, this makes my blood boil.
I see this happen, and it is a massive systemic failure.
So the radiation oncologist writes a beautiful, detailed note. Hold osimertinib during radiation. The patient finishes their 5 fractions, rings the bell, and goes home.
This sounds like a success.
But crucially, no one documented who was supposed to restart the drug. The radiation doctor assumes medical oncology is handling it. The medical oncologist thinks the patient just restarted it automatically.
And the patient assumes the drug is permanently prohibited because the, quote, radiation doctor told them to stop it.
Exactly. 6 weeks go by, they lose critical systemic treatment time, and their brain metastases explode.
Or you see the exact opposite danger, right? An automated calendar in the EMR prompts the patient to restart their immunotherapy on a specific date.
Yeah.
But on that date, the patient is actively coughing up blood and requiring 4 liters of oxygen due to acute radiation pneumonitis.
And the drug restarts automatically without a human clinical reassessment. You are basically pouring gasoline on the fire.
So the safety fix here is non-negotiable. You must rigorously document a restart plan.
Always.
You state the exact date of the last dose, the clinical reason for the pause, the explicit criteria required to restart, like resolution of cough to baseline, and you clearly name the clinician who officially owns the decision to flip the switch.
And usually that is the medical oncologist.
Right. Okay, let's fast forward 4 weeks. Your anchor case patient returns to the clinic for follow-up. They report an increasing cough, worsening dyspnea, and maybe a low-grade fever.
Okay.
You pull up a chest CT, and there is a massive new pulmonary opacity right where you treated them.
The immediate instinct.
I always want to call it radiation pneumonitis immediately. It is the strongest cognitive bias we have.
It is?
We gave radiation, now there's a lung opacity, ergo radiation pneumonitis.
And that anchoring bias can literally kill the patient.
How so?
Well, radiation pneumonitis does typically appear weeks to months after treatment. But you must force yourself to broaden the differential immediately. Is it a bacterial pneumonia?
Right.
A pulmonary embolism? Heart failure? Explosive malignant airway obstruction? Drug-induced interstitial lung disease? Or immune-mediated pneumonitis?
So how do you actually differentiate clinically?
You look at the temporal relationship and the spatial relationship.
Okay, break that down.
If the opacity strictly respects the straight-line borders of your 20-gregule acidose line, that leans heavily toward radiation injury.
Because radiation travels in straight lines.
Exactly. But if the infiltrates are bilateral, migrating, or in lung tissue that received less than 5 grays, you need to be thinking about drug toxicity or infection. You check their white count, their D-dimer, their fever curve.
And the overriding rule here is to stop guessing early. Don't assume you know what it is based on a quick glance at a scan. Prove what it is.
Yes, prove it.
If the patient has moderate or severe hypoxia, you halt both the radiation, if it's still ongoing, and the systemic therapy, and you initiate a prompt, aggressive medical workup.
We also need to warn you about the FDG-PET surveillance trap.
Oh, this is a huge one.
Right. Post-radiation inflammation involves massive macrophage infiltration. Macrophages are highly metabolically active, and they will just devour glucose.
So they light up on the scan.
Exactly. So if you get a PP scan 3 months post-treatment and the irradiated site is intensely avid, it does not automatically mean local tumor progression.
It could just be inflammation.
Yes. If distinguishing between inflammation and progression actually changes your systemic management, you need tissue confirmation, not just a hotter SUV on a scan.
That is such a crucial point.
Right.
Well, this brings us to the synthesis. We are going to isolate 3 oral board traps that trip people up constantly, and then we'll hit the rapid review.
Sounds good.
Trap number 1, starting your answer with dose and fractionation before naming your intent.
The faulty logic here is thinking that a technically impressive, beautifully conformal dose distribution is the answer to the clinical problem. It isn't.
Right.
A palliative plan and an ablative plan are making 2 completely different promises to the patient. The corrective move is to explicitly state, my goal is symptom relief, or my goal is durable local control.
Once you name the intent, then you explain why your technique fits the biology.
Exactly.
Trap number 2, reciting 1 fixed, rigid hold interval for every single patient receiving the same drug.
The error there is ignoring context.
Yeah.
As we discussed with osimertinib, treating a peripheral rib metastasis is biologically completely different from treating a massive central hilum.
Right.
The corrective move is to name the specific agent, concern like overlapping mucosal injury or pneumonitis, acknowledge the limitations of the retrospective data, and then outline a patient-specific plan that includes the MLD and explicit restart criteria.
Perfect. And trap number 3, calling every post-treatment pulmonary infiltrate radiation pneumonitis.
Premature closure. Anchoring on radiation pneumonitis delays the diagnosis of a deadly infection or a massive PE.
Yeah.
The corrective move is to objectively assess oxygenation, map the imaging finding directly onto your radiation dosimetry, and aggressively rule out life-threatening alternatives before assigning causality to your beam.
Let's rattle off the 6 clinical pearls derived from the source material. Rapid-fire takeaways for the clinic. Pearl 1. Always name the radiation intent before discussing the technique. Biology over physics.
Pearl 2. In metastatic non-small cell lung cancer, systemic therapy is the disease-wide backbone. Radiation addresses a defined local problem.
Pearl 3. Urgent, pressing symptoms like airway obstruction or bleeding may fully justify local treatment before you can achieve a theoretically perfect pharmacologic drug washout.
Pearl 4. Drug hold decisions are not binary. They depend on the specific agent, the field anatomy, the volume, prior toxicity, and the very real harm of interrupting a drug that is controlling the disease.
Pearl 5. Thoracic lung irradiation demands extreme caution with osimertinib, ALK inhibitors, and in any patient with prior immune-mediated pneumonitis. Furthermore, anti-angiogenic exposure in your central airways or vessels is a massive hemorrhage risk.
Pearl 6. A rigorously documented restart plan coordinated directly with medical oncology is not just administrative paperwork. It is a critical, life-saving safety intervention.
Okay, time to put you in the hot seat.
I'm ready.
Let's do the board blitz. 3 rapid review questions. Question 1. A patient with metastatic non-small cell lung cancer has a symptomatic thoracic lesion. The medical student proposes SBRT because, quote, it is more definitive. What is your first correction to that statement? Let's let you listening think for a second.
The correction is immediately unlinking technique from intent.
Right.
I would explain that SBRT is merely a method of delivering radiation. If the goal is truly durable ablation, we must prove that the disease pattern and systemic response support an oligometastatic or oligoprogressive biology.
We don't use SBRT just because it looks modern.
No, we use it because the biology warrants durable local control. If the goal is simply palliation of a cough in a widely progressive patient, a shorter conventional fraction scheme is often much safer and more appropriate. Technique does not determine the clinical promise.
Nailed it. Question 2. A patient receiving osimertinib needs thoracic radiation that will include a meaningful volume of lung. Which of the following is the best approach? A. Continue the drug automatically because no prospective trial proves harm. B. Stop the drug for a prolonged fixed interval of 3 weeks in every single patient. C. Coordinate an individualized plan using urgency, lung exposure, prior toxicity, and explicit restart ownership. Or D. Cancel the radiation entirely because the combination is absolutely contraindicated.
The best answer is unequivocally C.
Let's hear why.
Well, we know retrospective data show a clinically important pneumonitis signal, strongly associated with the mean lung dose. However, simply holding the drug didn't show a statistically significant reduction in pneumonitis in the largest series, likely because the biologic damage to the EGFR repair pathway requires nuance, not just a calendar pause.
Right, it's more complex than that.
Option A is wrong because absence of prospective data isn't proof of safety. Option B is wrong because prolonged holds invite dangerous disease flare and loss of systemic control. And option D is wrong because it's not an absolute contraindication if the clinical urgency demands it.
Perfect. Final question of the blitz. Several weeks after thoracic radiation delivered near systemic therapy, your patient develops a cough, dyspnea, hypoxia, and a new pulmonary opacity. What is the best first response? A. Diagnose radiation pneumonitis and start steroids. B. Diagnose immune pneumonitis because systemic therapy is active. C. Assess severity and oxygenation, map the opacity to your dosimetry, and urgently evaluate for infection, PE, progression, and drug toxicity. Or D. Wait for the next scheduled surveillance scare.
The answer is C. Management-changing clinical medicine requires determining whether the patient has a life-threatening reversible process.
Options A and B are just too fast.
They are profoundly unsafe because premature anchoring can mask a deadly infection or an embolus. And option D is just malpractice. Progressive hypoxia requires immediate aggressive coordination between the oncology teams.
The durable lesson from everything we covered today is that integrating radiation and systemic therapy is a structured, highly nuanced biologic risk decision. It is never just a memorized calendar.
Exactly. Name the local intent. Identify the exact systemic agent and the shared normal organs. Balance the toxicity you are trying to prevent against the disease control risk you are creating by holding the drug.
Optimize the dosimetry, document the restart owner, and when toxicity does appear, forcefully broaden your differential diagnosis.
Well said.
I want to leave you with a final provocative thought to mull over. We touched on this briefly, but it is really the absolute frontier of our field.
Oh, this is the exciting stuff.
Yeah. Think about the patient whose disease is broadly controlled by a highly effective targeted therapy like osimertinib, but they develop acquired resistance and progression at just one or two isolated sites.
Right.
Utilizing local ablative radiation to those specific sites might eradicate the resistant clones and allow the patient to stay on that life-extending drug for years longer.
It's the oligoprogressive paradigm. But doing so demands incredibly careful biologic selection. You cannot base the treatment decision merely on the fact that we have the technical ability to target the lesion with SBRT.
Right. Just because we can doesn't mean we should.
Exactly. How do we distinguish the patients who truly have a favorable limited progression biology from those where the systemic dam is completely broken and we're just playing highly expensive toxic technical whack-a-mole?
That is the perfect question to end on, and it perfectly sets up our next review session. We will be diving into exactly that, asking which patients actually benefit from oligometastatic or oligoprogressive local therapy and the biologic markers that guide that choice. Get show notes and complete practice oral boards at radonSmartLearn.com and subscribe for our next episode. Thanks for tuning in.